have a low total magnesium or you have a normal ionized magnesium. So in this case, this is what I call ionized magnesium total magnesium mismatch. Now, in patients with diabetes, this study found that patients with low magnesium are these 2 points on the graph on the right. And this part to the left says these are patients where you have a low ionized magnesium and a low total magnesium. Whereas to the right, you have patients who had a low ionized magnesium and a normal total magnesium. And if you look at the statistics for this slide, you'll see that in this particular patient population, only 25% had ionized magnesium, total magnesium trending in the same or agreeing, whereas in this case, 75% or 3/4 would have had, if you tested only total magnesium, normal magnesium levels, whereas in reality, if you look at the ionized magnesium part, they're in hypomagnesemia. So if you consider this, in these particular patients, if you were taking clinical decisions based on total magnesium, you would not correct for low magnesium in these patients, and this will potentially expose them, as we saw in previous slides, to insulin resistance, rapid disease progression, and these negative outcomes that we described in previous slides. But that's just the case of diabetes. Now let's consider some other instances in the clinic where magnesium and eventually ionized magnesium is clinically relevant. Situations such as in the cardiovascular OR, where things like acute kidney injury and atrial fibrillation are common complications. We'll talk about the relationship between magnesium and these complications in these patients. Another example is in oncology and onconephrology, where you have different kinds of cancers relating with hypomagnesemia, and then in transfusion and transplant medicine, OBGYN, and the neonatal and pediatric ICUs, just to name a few. Spend some time now talking about the cardiovascular OR, where research shows that up to half of patients undergoing cardiac surgery develop post-operative acute kidney injury. This AKI in these patients is responsible for up to 60% of mortality, and up to 2/3 of these patients are going to be placed on permanent dialysis. Now, research also shows that low magnesium in the pre-op period is associated with post-operative AKI. And due to this, most cardiac ORs supplement magnesium before the surgery and even during the surgery to prevent post-op AKI. However, research also shows that high magnesium levels in the post-op period is also associated with post-op AKI. What this means is that if magnesium is given indiscriminately or given without particularly measuring, then you expose some of these patients to post-operative AKI. So some centers have attempted to titrate the magnesium supplementation to serially measuring total magnesium or magnesium what's available intraoperatively, but this is a logistically cumbersome process because, as you know, to measure total magnesium, you need to collect the blood, send it to the lab, spin the blood, collect the serum, run the sample before getting the results back in about 20 to 30 minutes. And this is not ideal in a per-op period to measure and react to these magnesium levels. So if you can measure ionized magnesium in a more physiologically active part, but also you can do it in the OR more effectively, then you can better serve these patients by reacting to the levels of magnesium that you get in the moment. Another case where it is very important to measure magnesium in this cardiovascular OR is because one of the most common risks of cardiac surgery, accounting for up to or complicating up to 50% of cases, is post-operative atrial fibrillation, which is also associated with increased mortality, morbidity, and length of stay in hospitals. Now, research also shows that low magnesium levels is associated with post-op atrial fibrillation, and magnesium supplementation in these patients has been shown to have a beneficial effect in preventing POAF or post-operative atrial fibrillation. For this reason, researchers in Japan of 5 different societies recently found consensus regarding ionized magnesium monitoring in open heart surgery, and they recommended that real-time measurement of ionized magnesium is desirable for setting target values of magnesium correction for prevention of post-op arrhythmia and for determining the efficacy of treatment. They also mention that it is difficult to estimate IMAG from total mag measurements in the post-op state, so post-op magnesium correction of interest based on IMAG is important compared to total mag. Another instance where magnesium is particularly important in the clinic is in oncology or onconephrology. Now, in oncology, patients who are suffering from cancer have reduced intake of magnesium. So because they don't have appetite, they have reduced intake of magnesium. Because they have low body mass or muscle wasting, they have low reserves of magnesium. Another thing is because of things like emesis and diarrhea, they have increased losses, and through the kidney as well, due to some of the drugs that they are taking, they also have kidney losses. So these compound and lead to low levels of magnesium almost chronically in patients living with cancer and on treatment. Now, some particular specifics to this case of magnesium and cancer. You have certain anti-oncology drugs such as platins, which are known to cause magnesium wasting. So in these patients, it's very important to do magnesium supplementation, and this supplementation most times is based on a serial measurement of magnesium levels, which in this case, in most cases, is done in total magnesium, but can be done in the moment if you titrate during the treatment with platins to ionized magnesium, which can be measured more quickly. Another instance where magnesium levels are important is in transfusion and transplantation. As you transfuse blood, as we know, the blood, to keep it fluid and to stop it from coagulating, it's pumped with citrates. Now, these citrates, as we mentioned when we're talking about the physiology of magnesium, can bind the ionized part of magnesium and form the chelated part. So what happens in this particular instance is that while you have the same level of total magnesium, when you have a patient that has just received a transfusion, because of this increased level of citrates in the blood, you have a reduced or reduction in the ionized form of magnesium, even though the total form stays the same. Now, in these patients, if you test only for total magnesium, you see no difference in the magnesium levels before, during, and after the transfusion. But if you measure the ionized magnesium, you can see how the levels change, reducing after the transfusion and normalizing after time if the patient has a normal homeostasis to balance the transcellular movement of magnesium. Now, while this happens during transfusion, the same thing happens during transplant surgeries, because during these surgeries, most of the time, these patients are transfused with blood. But in addition to this, there's certain immune suppressive drugs such as calcineurin inhibitors, which can lead to magnesium wasting, further exacerbating the low magnesium levels or low ionized magnesium levels in these patients. Now, low magnesium levels in these patients have been associated with decreased immunity, insulin resistance, as we mentioned earlier, and this can lead to graft rejection in both kidney transplants or liver transplants, and also it is responsible for post-transplant diabetes mellitus, which is one of the common complications of transplants of solid organ transplant surgeries. Moving on to OBGYN and the use of magnesium in this space, many of us may be aware of the preeclampsia, which is a common complication of pregnancy and which leads to adverse outcomes both for the mother and for the fetus. Magnesium sulfate has been shown from decades past to be more effective in preventing seizures in women with preeclampsia than other anticonvulsant drugs. Now, the goal of therapy with magnesium in these patients is to keep the magnesium within a narrow therapeutic index, or a narrow therapeutic index of about 3.5 to 7 milliequivalents per liter. Now, because it's you want to prevent magnesium toxicity and associated risks in these patients, regimens vary from bolus to IV to IM or titration based on what's available and the level of risk in these particular patients. Now, in my experience, when you ask different OBGYNs, they apply different protocols based on different evidence that they have in their environment. But the truth about magnesium homeostasis or magnesium metabolism is that two patients never have the same rate of metabolism of magnesium. So while the evidence of the research may show that 5 grams or 4 grams or 8 grams may be effective in treating preeclampsia, the truth is somewhere in the middle, because each patient is going to react differently to the magnesium that they're given. So it's arguable, or it's arguable that titrating or knowing how each patient responds to the magnesium that they're receiving, so you know where to give, whether to give them more or to give them less, is more effective than just blindly administering magnesium in these patients based on other trials that were done in different patient populations. So in this particular case, titrating for magnesium levels would give you a better idea if you're within this therapeutic level of therapeutic index of effectiveness in preventing seizures in these patients to avoid magnesium toxicity or hypermagnesemia. Finally, having just spoken about the OBGYN, let's talk about the babies that are born. Now, magnesium has been shown to be neuroprotective in newborns of mothers who are pre-eclamptic. So we just spoke about preeclampsia. If you give magnesium in a specific therapeutic index, it's been shown to be neuroprotective in the neonatal period. Also, magnesium supplementation is helpful in preventing arrhythmias, just like in adults, in patients or children that go through cardiac surgery, whether for congenital heart disease or for any other heart disease. Magnesium supplementation has been shown to be preventive of arrhythmias. Now, both low and high magnesium can increase the risk of death, so keeping magnesium level within a specific range in these tender patients has been known to improve or reduce the risk of mortality. In all of the previous examples or clinical situations where we mentioned magnesium being important, even critical, ionized magnesium may even be more important for pretty much the same reasons. First situation is if we need quick results. Because total magnesium requires you to collect whole blood, spin the sample, collect the serum, and then measure the magnesium. This process usually takes about 20 to 45 minutes because it's done in the core lab. However, ionized magnesium can be done on whole blood, and you can get the results with some devices as quickly as in 45 seconds compared to the 45 minutes it will take you to get total sodium magnesium. In addition to that, in all of these cases where you look at only total serum magnesium, you may be missing some cases of masked hypomagnesemia. In this, when we mentioned before the mismatch between total magnesium and ionized magnesium, this is the case where total magnesium is normal, but then ionized magnesium is low. And this leads to masked or undiagnosed hypomagnesemia. In these patients, we who are looking at total magnesium may consider the patient to be normal magnesiemic, but the body recognizes that the blood is hypomagnesemic, and if we're not supplementing in these cases, we may be exposing these patients to poorer outcomes and complications and sequelae as well. And finally, the last case where ionized magnesium may be of importance in these particular clinical situations is the case where you have a low total magnesium, but then a normal ionized magnesium. And these are the cases where we can call them the pseudo-hypomagnesemic, which would mean patients in this group may be inappropriately diagnosed with hypomagnesemia. And because of that, they may receive magnesium supplementation, which is not necessary, and it may even be dangerous to them. So it has economic impact on the hospital or the healthcare system that's administering this treatment, but also clinical effects, clinical outcomes that can be negative in this case, where patients receive magnesium supplementation that's not needed, and they may actually go into magnesium toxicity or hypermagnesemia. So there's this, this demonstration that just summarizes what we just said before. On this left side, it describes total magnesium and the differences between the measurement of total magnesium versus the measurement of ionized magnesium and the benefits of ionized magnesium in this case. This graphic is taken from this paper, which was published by Scopardi and his collaborators in 2020. Now, after all that has been said, the question is who should pay attention to magnesium? Historically, magnesium compared to other ions such as iron and calcium has been studied very, relatively little compared to the other ions, other cations in the body. And there are several papers dating few decades ago, a few years ago, that identify magnesium as a forgotten electrolyte or a forgotten mineral. However, studies have shown that magnesium has profound, magnesium dysmagnesemia, high or low, can have profound impact on the outcome of patients, irrespective of diagnosis. So this graph on the right just shows us the comparing papers that have been published. The blue is for iron, green is for calcium, and the yellow at the bottom is for magnesium. So by and large, magnesium has been considered a forgotten electrolyte compared to the other cations that are being studied. But the question is, should clinicians pay more attention to magnesium? And the answer to this question can be presented in the form of a study that was done by Salinas and collaborators that was just published earlier this year. And basically what they did is they identified certain patients that were at risk of dysmagnesemia, or mostly at risk of low magnesium levels. And these patients were patients who had a calcium level lower than normal, potassium level lower than normal, patients who are diabetic, hypertensive, or above 65 years old, and patients on proton pump inhibitors for a long time. Now, all of these patients, research has shown that they are at risk of low magnesium levels. And so what they did is basically the LIS prompted a question when any of these patients was met in the ED. And if the clinician did not request a magnesium test, the LIS is going to prompt the clinician and say, hey, this patient is at risk of having a low magnesium level. Would you consider testing for it? And more often than not, the clinician clicked yes, and the test was requested. And also, if there was any patient that had a low serum or plasma magnesium level in the ED, the LIS prompted again after these results that this patient has a low magnesium level. Would you consider supplementing based on your clinical assessment? And more often than not, also the clinicians clicked yes and supplemented in these cases. So the analysis begs the question, what were the rewards, or what was the result of the study that was done by this practice that was done by Salinas and the collaborators? And basically what they found out was, so in the first case, which is patients who were hypocalcemic or hypokalemic, what they found was, this is what they found in these patients. But after the intervention of just, LIS requesting or prompting the clinician to request for the test, what they found was there was a 50% reduction in the readmission rate. Because the explanation for this is, in patients who have hypocalcemia and hypokalemia, if they also have hypomagnesemia, because the cellular shifts of these ions is similar in many of these cases, if you don't correct for the magnesium, but then you correct for the calcium and potassium, the patient is going to have refractory, or the hypocalcemia and hypokalemia is going to come back. Whereas in these cases where they found out that there was low magnesium as well and corrected for the low magnesium, these patients did not have refractory hypercalcemia or hypokalemia. So this led to a 50% reduction in the readmission rate of these patients with hypocalcemia and hypokalemia. In addition to that, if we're talking just about the patients with diabetes, what they found was, in patients that they would normally, the LIS didn't prompt in these cases, they found hypomagnesemia in only 15% of these cases. But then in the cases that were diabetic, where the clinician did not request for a magnesium test, but the LIS prompted and it was requested, they found a 75% prevalent of low magnesium level. What this means is this is a 500% increase in prevalence rate of low magnesium levels in patients with diabetes. So what this means on the flip side of the coin is, if this magnesium was not tested, only 15% of patients probably would have gotten the supplementation that they needed, and the rest of the 60% that would have been undiagnosed in this case would potentially have been exposed to what we saw before, which is the insulin resistance, refractory hyperglycemia, rapid progression of the disease of diabetes itself, but also other negative outcomes such as heart failure and kidney failure. So in this case, this was another example where a 500% increase in prevalence rates of low magnesium levels permitted them to act on these low magnesium levels, and we'll see what the impact on the treatment was in the next slides. In conclusion, however, what we can say is, in many clinical settings and disease states, magnesium is often overlooked but has profound impact on patient outcomes. Magnesium exists in various forms. The physiologically active part is ionized magnesium, but this is not routinely checked because it's not readily available. There's not too many devices out there that can test for ionized magnesium. However, there are a few, and if you can test for the physiologically active part, it is considered to be a more reliable indication of the real magnesium status of the body. Now, in several clinical situations, such as diabetes, in the cardiovascular OR, in onconephrology and oncology, in labor and delivery or OBGYN, in transplant medicine and transfusions, magnesium is extremely important and sometimes even critical. Physiologically accurate and quick results in these clinical situations may make a significant difference and have a profoundly positive impact on patient outcomes. And as we just saw in the Selena study's results, if there is a proactive collaboration between the lab and clinicians, you can have improved outcomes just by improving improving the testing for low magnesium or the magnesium levels, detecting low or high magnesiums, and acting on this based on your clinical knowledge. Thank you all for your kind attention, and I'll be more than happy to take any questions. Is because one of the most common risks of cardiac surgery, accounting for up to or complicating up to 50% of cases, is post-operative atrial fibrillation, which is also associated with increased mortality, morbidity, and length of stay in hospitals. Now, research also shows that low magnesium levels is associated with post-op atrial fibrillation, and magnesium supplementation in these patients has been shown to have a beneficial effect in preventing POF or post-operative atrial fibrillation. For this reason, researchers in Japan of 5 different societies recently found consensus regarding ionized magnesium monitoring in open heart surgery, and they recommended that real-time measurement of ionized magnesium is desirable for setting target values of magnesium correction for prevention of post-op arrhythmia and for determining the efficacy of treatment. They also mentioned that it is difficult to estimate IMAG and total MAG measurements in the post-op state, so post-op magnesium correction of interest based on IMAG is important compared to total MAG. Another instance where magnesium is particularly important in the clinic is in oncology or onconephrology. Now, in oncology, patients who are suffering from cancer